Welcome to Unmasking Dementia Lived Experiences, a podcast featuring families who have navigated the challenges of dementia. Through heartfelt stories, we will delve into trials, triumphs, and wisdom gained along the way. My name is Christiana. I'm a registered nurse, dementia advocate, children's author specializing in dementia education, memory care specialist, owner of reputable memory care facilities in Toronto, Canada, as well as the founder of a Roosevelt Grammar Wellness Hub, a charitable organization that caters to the needs of communities of Black, Indigenous, and people of color. Hello, everyone. I have a very interesting guest joining us today. I've actually been looking forward to this interview for quite some time. Dr. Saskia Sivananthan is a leading healthcare leader and passionate advocate who has worked with multiple health systems and organizations nationally and internationally to build strategies and solutions for older adults. He now roles as both affiliate professor in the Department of Family Medicine at McGill University and former Chief Research and Knowledge Translation Officer at the Alzheimer's Society of Canada. She has been instrumental in raising the profile of the needs of people living with dementia in Canada. In 2020, she was appointed by the Federal Minister of Health to the Ministerial Advisory Board on Dementia. Previously, Dr. Sivananthan, I'm going to call her mostly Dr. Saskia, served as a senior strategy and policy advisor, consulting for the World Health Organization on its global dementia strategy. She co-drafted the World Health Organization's Global Action Plan on the public health response to dementia, which received unanimous consensus at the World Health Assembly. This plan served as a template for Canada's National Dementia Strategy. She has served as the World Health Organization's representative at OECD, European Commission, EU Joint Program Neurodegenerative Disease Research, and Alzheimer's Disease International, working to coordinate global relationships and advocacy activities on dementia. And the list goes on and on from here. However, what has impressed me most about Dr. Saskia is her commitment to the saying, "Be the change you want to see." She embodied this by living as a patient in a nursing home for a couple of weeks. Just imagine that. And she did this as part of her research. This is something many people will find extremely challenging. Ageism is a significant problem in our society today, and immersing herself in an environment with elderly individuals, many of whom have medical needs, demonstrates her passion and compassion. So let's dive into some questions. Dr. Saskia has a wealth of eye-opening information to share with us tonight. So welcome. It's been such a long time waiting to speak to you, so you are here finally.
It has. Thank you so much. It's a pleasure to be here, and thank you for that introduction. It was very kind of you.
Yeah, you know what? You've worked for it, you've earned it, and you are still doing so much to change the landscape for people living with dementia, especially in the BIPOC community. That is communities of Black, Indigenous, and people of color. So please tell us about your background and experience in dementia research, especially within the BIPOC communities.
Sure. So I'll start by saying that I trained as a neuroscientist first, so really doing bench clinical work. And I didn't get to see a lot of patients or people living with dementia because my work was really focused on understanding the brain and how everything connects and why it is that Alzheimer's was impacting the brain in the way it was. But I realized as I was doing this work partway through my grad studies that I needed to connect the disease with the people who were living with it. So I started volunteering at a memory clinic. It was the first memory clinic established in Canada in Montreal. And they didn't actually know what to do with me when I asked if I could volunteer because I'm not a clinician. Yeah. And they said, well, you're the first graduate student who's asked this, from the neuroscience department, but we'll figure it out. And they did. So I started doing the cognitive tests, the intake tests that happen when a patient first comes into the clinic. But as part of that, I also got to sit in on the family discussions, on the counseling sessions. And so I started hearing how difficult it was for people to first come and get a diagnosis, but then once they got that diagnosis, what do they do next? Where do they go next? And that is what actually inspired me to change my entire trajectory. I did finish up my neuroscience degree, but then I went back to school, this time for a population health degree, because I wanted to change the policies that were impacting how the system worked. So that's really my training and background, and ever since then, I've used it to work within health systems, but also during my work at the Alzheimer's Society, you're working really directly with people living with dementia and their care partners, and that really inspired a lot of the research I do. So over time, I started finding ways to engage and co-design research. So not just having, and this happens a lot with scientists, there's a really exciting, interesting question we want to answer, and then you go off and you do it. But the research is not always connected to the reality of what people with, right? And that was what was important to me, that intersection of answering questions that were the reality of how people were living with and dealing with dementia. So that's really been the trajectory of the kind of research I do. And of course, for BIPOC communities and diverse communities, the lack of knowledge that we have in understanding how our communities are dealing with this disease, what their needs are, is astounding. We don't fund enough of it. We don't have enough researchers from those communities who are designing that research or co-designing it with communities. It's starting to change, but it's still not enough. And so that's part of the work that I also do.
That is amazing, because you have to put the face of the person that you are dealing with to your research, because there's that disconnect, and people always say, how did they know that? Like, I think when my sister first had a baby, about 40 years ago, there was this doctor, I'm not going to say his name, who had all these things to say about babies and how they should be raised and let your baby cry and everything. And she told me later, you know what? I found that he didn't even have a child. So how would he know? So you have to definitely know. And I know that was a passion that drove you to live in that nursing home, put a face to what you're researching about. And it is so important. And people tend to, gravitate towards that type of research and those type of information when somebody knows that you understand their pain, you understand where they're coming from, especially in our communities, the BIPOC communities, where we are so closed off. We don't want to talk and stuff like that. You have to actually have the goods to deliver for people to trust you. So I applaud you for the work that you are doing. So I think you more or less answered my next question, which is what your inspiration is for focusing on dementia research within the BIPOC communities. So,
yes and no, actually. I'll tell you a bit of a story as well that really inspired the work specifically within the BIPOC communities. So I have some lived experience of dementia. My grandmother didn't have dementia, but she did have a neurological disorder, and that really impacted her right at the end stages of her life. But one of the things that really inspired me watching her was she had purpose. She had a sense of purpose all the way through. She was engaged in her daily activities, in our day-to-day lives. She lost her vision. She actually lost her vision in both eyes, but it didn't stop her from cooking. She would still chop vegetables. She would still, do the laundry. She would fold the laundry because that was part of her purpose in the household. And I think that's been part of the realization with understanding that within BIPOC communities and that the values that we have and the purpose that we have can be different. And if you don't understand that first, then it's very difficult to also be able to design programming, to design supports, to then support people from those communities. You're absolutely right, though, Christiana. Without the trust building to really deliver, that's definitely another aspect to it. And so this is also why in the kind of research that we do, we really, and what I have often asked for is co-design. So it's not the researcher coming in and saying, this is what we do it. It's asking people, what do you need? Is this the kind of approach that would work for you? And bringing them along that whole process. When I lived in that long-term care home, I met a gentleman who was Sri Lankan Tamil. He was one of the few South Asian people living in that home. I'm South Asian as well. And he saw me and he started talking to me in Tamil. Now, I don't speak Tamil. I understand a bit of it, but I don't. And I realized that he actually had severe dementia. And so he had lost all other language skills except for his mother tongue, his original tongue, which was Tamil. But also the staff couldn't really engage with him. They couldn't really explain to him what was going on. The other residents couldn't really interact with him. So he was incredibly isolated. And so, yes, his daily needs were being taken care of. His body was being taken care of, but not what would really have fulfilled him at that stage of his life. And I want that to change with how we care for and support people living with dementia.
That is really important. It's like one of my books, I gifted it to a friend of mine who works with home and community. And she fosters some children, especially children with disabilities. And she actually had him reading this book. And what he remarked that was most important for him was that the characters looked like him. So that recognition, seeing you in other people. I remember again, there was a day that a lady came to Alexis Lodge to look for a bed for her mom. The minute she walked in, she was like, oh my God, thank God I met you, because I was feeling so bad and guilty looking for a home for my mother. And then I had to sort of, talk to her about guilt and stuff like that. So knowing that there are people out there that understand, what you're going through is so important. So I'm really happy with the work that you're doing, the way research is now being done. It's like the inclusion is so important because a lot of people living with dementia actually have a say. I think there's this, I don't know if it's an article or something about, do you see me? I think I listened to the lady talk and she said, the minute the doctor says you have dementia, they start talking to your loved one and ignore you, right? But you are still there. So these are things that we all need to be, very sensitive about, give that respect where respect is due and treat them just like, the rest of us. So.
Absolutely. And I think that what you just said, do you see me? Because dementia, the stigma around dementia, how we think about being old generally, that ageism, it makes you invisible.
Yeah.
And one of the strong messages, I've heard and we've received from people living with dementia from all communities is nothing for us without us. Because they want to have a say, they want to design for their needs. And we can't do that alone because we don't know what their needs are. We can we can appreciate, observe, and support it and build together. But absolutely, that is important. But going back to one of your other points as well, in BIPOC communities, we are very private. We don't talk about mental health. We don't talk about struggle. We don't talk about diseases like dementia. We don't even talk about burnout until it's gotten to essentially a crisis point. And while some of those I understand where it comes from a cultural perspective, I think you have to understand where it comes from before you can start working together to change. But you cannot come in and push education down people's throats and push programming down and expect them to just accept it or to come to you just because you're offering it. Meeting on that level is so important. Meeting people where they are and bringing them on that journey, and that's been an important lesson for me.
Yeah, and especially a society or a culture that is really high on respect. You know, and there's this trust for doctors as well, but you have to sort of speak their language, not necessarily the dialect, but at least just that understanding of where they are at, where they're going and where they're coming from. It's amazing. So that is why you guys, like you and your team, and a lot of the new research that is out there is really hitting the point and getting it. And hopefully with this, more people will benefit, and there'll be more successful research being done, and also suitable programs being developed from all this work that is being done to help. So my next question for you is, we know that there are healthcare challenges, the health system that needs a lot of change. So what do you think, or what do you believe these changes have to be to address this population with dementia, especially in the BIPOC communities?
It's a big question. We're going to solve all the world's problems in this podcast. I think one of the things that really strikes you is our health system was built decades ago to really address acute, immediate issues for young adults. And by young adults, I'm saying between the ages of 20 to 45. It's not designed for people who have multiple chronic diseases. It's not designed for older adults. It's not designed for even middle to late adulthood. And it certainly isn't designed for dementia. And I think the sooner we recognize that, the sooner we can start rebuilding part of that system. So, for example, think about acute care as a hospital. When you take someone living with dementia to the hospital, it is a very traumatic visit experience, exactly, for both them and for the caregiver and the person who's taking them there. Because the hospital system, especially the emergency system, is really not going to be able to support this person who's living with dementia. If anything, it often causes more delirium. If the person is kept in the bed for long periods of time, it causes weaknesses, obviously, in their muscles generally. It can trigger behavioral outbursts and concerns, which are totally normal if you understand what the person is going through and what they're trying to express themselves as. But you can't, so that system, when you're taking a loved one there, is just not set up for that. And then the other piece in which I think that from a health system perspective, that we don't do enough around dementia, outside of course, acute care, is long-term care. Long-term care takes a very medical approach to aging and to dementia. And so we take care of a person's body, their physical needs, their nutritional needs, but we're not truly taking care of them holistically as a person and addressing their values, addressing their purpose. And this is why I think you tend to hear a lot of that guilt. You hear guilt from people who are looking for long-term care and supports from any community, but you especially hear it from people from the BIPOC community, because that sense of respect, of filial piety, of responsibility to take care of your parents and ensure that they have a good and respected life, you can't meet those needs anymore in long-term care. But at the same time, you can't meet their needs at home anymore, because it has gotten to the point where you don't have home care supports to enable that. So there's a lot that needs to be rethunk, that we need to rethink. But I think the most important takeaway is that it is possible to find a solution. None of these are impossible problems. They're not impossible solutions. Humans created these health systems. We created these health policies, which means it is possible to also recreate and change what is needed. It's going to be complex. It's going to take time, but it's possible to do it. So I think those are sort of more at the health system level issues. But I'll give you another example of a project that I was working on when I was at the Alzheimer's Society of Canada. We recognized that we were not seeing and hearing from people living with dementia from diverse communities. And so we started a helpline because we understood that people wanted to talk confidentially and have their questions answered. And that made a significant difference in being able to ask and get accurate evidence-based information. And we were now starting to hear from people from diverse communities, people who had other language needs. And then we also started building guidelines for physicians, because your family doctor is your gateway, is the place at which you will get a diagnosis and then be able to access any management supports. And if your family doctor doesn't know how to diagnose you and is not culturally sensitive to your needs, then your whole trajectory after that goes downhill. I mean, if you could imagine a person living with dementia coming from the Nigerian community or from the Sri Lankan community, and now they're being given a cognitive test, but the cognitive test is more designed for someone of a European background or who would have had a European education. So are you truly testing them cognitively? And then have you talked to the family member? Have you brought their child in if their child is engaged or not? There's so many different ways that you have to think about all of this. So we started building these guidelines for disclosing a diagnosis of dementia, because we conducted a survey of family physicians across the country. 75% of them told us that they had a patient whom they knew had some form of cognitive impairment, but they hadn't told them. So they hadn't given them a diagnosis. Can you imagine that? Living with that kind of memory loss and not being told you have that diagnosis and not being given help and support for what to do next.
At a very critical time, because early diagnosis does make a difference. And that also brings us to the next question is, how do cultural influences affect the perception, diagnosis, and treatment of dementia within the BIPOC communities?
Yeah, and that's a great segue, because talking to a family doctor, and I'm not blaming the family doctor. I mean, the family doctor may not have the training, may not understand the cultural perceptions, but they are there. There is stigma around getting a diagnosis of dementia. It's a mental health disease. It's seen that way in a lot of different communities. In some communities, because of the lack of awareness that it is not a normal part of aging, people are considered to be possessed, or, that witchcraft has been performed on them, right? Because the society around them doesn't understand that this is actually a disease. And in some places, it's just considered normal aging. Oh, they're just getting older, and of course they're forgetting. But then it gets to the point where you realize this is not what it is. And so those cultural perceptions and stigma very much influence when people come to get a diagnosis. And generally in the research, people from diverse communities, especially if you speak a different language, tend to come later to get a diagnosis. And so that crucial, as you just said, that early diagnosis stage, that crucial stage is missed. By the time they come, they're sometimes at the moderate to severe stages. And it makes it much more difficult to be able to support them and to help with management. And often the caregiver has burnt out at that point. And so even if they could take care of them with the supports, they can't anymore because they've burnt out in their ability to do it.
Yeah, and there are so many negative results from misconceptions that happen. First is, the fear, because people don't understand. It's like, a family goes to the doctor, they have a family member that has responsive behaviors and stuff. They will not tell the doctor because of fear of confinement. They get to that, if you tell the doctor, they're going to lock them up forever. So education is so important. And that is what I'm trying to do with this podcast and with my books. Just to start education from as early as elementary schools, like getting kids aware of, what dementia is, letting the parents and grandparents know, again, the BIPOC community, because we hide things, we tend to hide these things from children. And, when your children don't know what is really happening, and they may start internalizing their feelings, thinking their grandparents don't love them anymore. So those are really important as well. Like, the education goes beyond just family members and children, the community itself, because that is where a lot of the stigma comes from. When I take my residents out and they're acting funny, people start to stare. You don't have to, come help, talk to the person, make them feel good rather than making them feel weird and, out of place and stuff like that. As well, doctors and healthcare practitioners. Yes, not everyone may not understand what dementia is, but that education as well, and prompting primary care physicians to refer these people that they suspect or they diagnose of any form of dementia on to specialists, send them to clinics, send them to places where they can get more help and get more support. So it's a broad education that we need to be doing, like raising awareness and looking for ways to eradicate stigma. Because I believe that if we understand what it really means, if we know what people are going through, especially those people that are having difficulties of behavioral challenges, instead of labeling them as being difficult, understanding that they are going through difficulty, not that they are being difficult, and supporting them, it make it so much easier on everyone. And also, I personally try to educate families to let them know, home is the best place to care for your loved one, but then there comes a time when home is not good enough or not enough to meet the needs of that person anymore. So what you do at that time, go out, look for a suitable home. There are so many types of housing, like, you have retirement, you have nursing homes and so forth. But we also need the government at play here, because dementia care can be very expensive. And I look at the BIPOC communities, how many people from that community can afford the, astronomical care that, a lot of places that are not nursing homes offer. What is the middle ground? What can we do? Not everyone needs to be in a nursing home. And people should have choices, but we don't. We don't give people choices. If you decide not to go to a nursing home, you're on your own. No one will support you financially. It's really sad, because I think there are so many different level of care system or care housing and out there. So people should be supported and given that privilege to make the right choice for their loved ones, as well as supporting caregivers. See, caregiver stress is so real. And, especially in the BIPOC communities, when you are dealing with it, you're not even telling your friends, you're not telling your family, you're not telling your church community. So you become isolated. yes, people do get isolated anyway, because when people know about this disease, they fall off and you are alone. But, just giving that support, that caregiver can get respite care, not just for their loved ones, but let them get some support themselves. So those are really important things that I am sure you guys are working on with your research. And I hope that, just bring it forward so that we can look at not just the person with dementia, but also the family, because it's not just an individual disease, it's a family disease, and also impacts the entire community. So moving forward, is there research or programming you are aware of that address these issues? Some of the ones I've just mentioned as well.
Well, I think Alexa's Lodge is a really great example of an approach that offers a choice. And I think it's an important one that people don't realize sometimes how many there are, but also what is needed and the financial supports that are needed. I actually right now am working with a partner, and we are incubating a think tank called the Brainwell Institute. And the intention behind it is to be able to take research that's already been done, that exists, and to use it to help ignite these changes. Because all of the things you said, Christiana, are absolutely true. They're also things we have known for a long time, but we just have not used it and pushed enough to advocate for these changes. Even the things I've talked about are things that we've known for quite a while. But the value, how we value older people and how we value people living with dementia, it speaks to it when we're not willing to make these changes, given what we already know. Now, the general rule of thumb in research is it can take up to 17 years for good research to move into practice. And for people living with dementia, that's too long. You can't wait. No one can wait that long, but you really should not be waiting that long. And so our intention behind the think tank is to really help people use that research and that evidence to advocate for these changes, to speak to their MPs, to advocate for these health system changes, to advocate for caregiver supports, for respite care. Other countries have done these things. You talk, Christiana, about educating young children. Japan has been educating their elementary kids and their kindergarten kids about dementia for years. And it has shifted how they as a culture are starting to handle and think about dementia. And this is a culture where respect is very high, of course, for older adults and for that privacy. There are other countries that, for example, if you are a caregiver for someone living with dementia, instead of forcing you to put your loved one in long-term care, they give you the money and they ask you to use it as you need for your loved one. It's a set amount based on your needs, and you can use it to hire for help. You can use it for respite care. You can use it for residential care. You can use it for food, meals on wheels, whatever you might need. There are ways in which we can circumvent these things and really support people better. But it requires the government to really take an active role in meeting those needs from a policy perspective. And it requires the community to be able to talk about what their needs are and to ask for them. And so the longer and the more we hide those things away, we hide the disease and the person, and we live with that on our own, the harder it is for us to be able to push for those kinds of changes.
So true. So apart from the think tank, what other initiatives or projects are you involved in to address dementia-related concerns?
So I touched on it briefly earlier. One of the pieces of work that I was involved in was around guideline development for family. So we know family physicians are the place where you can get a diagnosis, especially in Canada. They're the gateway. And one of the juncture points was that they were not feeling confident enough to disclose that diagnosis to the person who has dementia. So we developed guidelines, and they're called the CLEAR guidelines, which are a very practical way with a script, very specific, clear, practical ways in which a family doc can then disclose this diagnosis. We teach them how to do it. But the important thing about that I want to highlight is it's one of the first guidelines in Canada that really focuses on BIPOC communities. So we designed it with cultural competencies for family docs for two communities, from the Black community and the Chinese community. And so this is where the co-designing came in. We had a working group of people from the Black community, people from the Chinese communities who were involved throughout the whole process in building these guidelines. And therefore helping family physicians understand if they have a patient come in who comes from this community, what do they need to consider from a cultural perspective before they talk to them about a dementia diagnosis? And then what do they need to do after they tell them that diagnosis? How do they support them? And so that's some more of the work that we're doing in continuing to build more of these guidelines to educate and support family physicians and healthcare professionals with cultural competencies.
That is wonderful. So my last question for you this evening is, can you emphasize the importance of community engagement and collaboration in advancing dementia research and support services for the BIPOC communities?
Yes, I would say that we often look to community champions as researchers, especially coming into a community that might not be your own, to work with a community champion and to really engage with the community. But that requires trust building. And I know that there can be distrust for research of healthcare professionals. And then there's all of the stigma that we have around this disease. And the communities need to come together. You have to work together. We have to be willing to tell each other these stories and share these needs in order to be able to really affect and push for change. And I'm not even talking about system change at this point. I'm talking about even educational changes within our communities where we're able to acknowledge, yes, my mom has dementia, or yes, my father is starting to forget things. And I don't know what to do about it now. And that is one of the first steps to then being able to get the kinds of supports that are needed. If we don't start talking about it, if we don't come together to collaborate together, we're going to continue to work in darkness. And this is not going to be a place that in the end will help anyone.
Yeah. Like the saying goes, united we stand, divided we fall. So this is something, like I often say, let's join hands together, to unravel dementia, the complexities, and like everything, like the stigma, they say problem known is half solved. So when we know what this is, when we understand it, and we can empathize and sympathize and, have compassion and sensitivity, it is so important. Again, yes, it's a devastating journey, but it's worse without the knowledge and support that people need. So, but when we come together and, also do things to eradicate that stigma, like the Alzheimer's, the National Ballet School of Canada is doing with dance. Dance and not dementia, eradicating stigma around dementia. So those type of things, community programming, because when you're dancing, you're not looking at your partner and saying, oh, maybe that person has dementia or this. No, you're just having fun. So what are the fun things that we can do? What are different ways that we can, help our seniors, intergenerational programs? There's so much that can be done. And I'm really happy that, and as you know, the dementia is growing at an outstanding rate, right? So now more than ever, we need solutions. We need action. We don't, like you said, I'm so happy that you have this think tank, because we don't have 17 years for research to mature. We need it today, or we needed it yesterday. So thank you for the good work that you are doing. I'm really, really happy that you got some time to spend with me this evening. I've been looking forward to it. And I hope that this is just one of the future visits you're going to have with us, because, as you continue to unveil things and create programs, I'll definitely want you to come here and talk to families, because lived experiences, it's so important when you know you're not alone, and someone else understands, and even if they can't walk in your shoes, but they know what it feels like, it just gives you that comfort. So thank you so much for coming.
It's my pleasure. Thank you for having me.
Yes, thank you. And I hope that you have a good night, and I'll talk to you again soon.